Hi, everybody. I hope you can hear me and see me. I'm Professor Ray Rogers, and I'm the Interim Director of the Robinson Research Institute. So with this being an online event, we are located in many places around the world. Myself, I'm hosting this lecture from Melbourne, which is on the land of the Wurundjeri people. And I wish to acknowledge them as the traditional owners. I would like to pay my respects to their elders, past and present, and the Aboriginal elders of other communities who may be here today. So the Robinson Research Institute hosts the annual Lloyd Cox Memorial Lecture to honour and to remember Professor Lloyd Cox. We are very happy to welcome David Cox, Professor Lloyd Cox's son. Thank you, David, for you and your family's ongoing support in this event. So you might be asking, who is Lloyd Cox? Well, in 1958, Lloyd Cox was appointed as the Foundation Professor of the University of Adelaide's Obstetrics and Gynecology Department, established at the Queen Elizabeth Hospital here in Adelaide. Cox had previously worked in New Zealand and in the UK, and his vision was for a department to be a world leader. He strongly believed that science and medicine should collaborate closely. He wanted ONG to be a science-based department and is credited with being the first person to bring infertility as a medical issue to the attention of mainstream medicine. Although Cox had a strong sense of discipline, he encouraged people to look at new ideas and to develop new techniques. During his time as head of ONG, Cox appointed Ron Cox as a biochemist. I don't think they were related. We believe this was the first ONG department to appoint a scientist. Also under Lloyd Cox's leadership, the first frozen semen bank in Australia and the first sperm donor program were established. Professor Cox retired as head of department in 1984 and was replaced by Geoffrey Robinson in the following year. And in the following year, ONG achieved South Australia's first birth from frozen embryos. And the Robinson Research Institute is named after Geoffrey. So today, we're delighted to have Professor Richard Anderson to present the 2022 Lloyd Cox Memorial Lecture. Richard, apart from being a long-term collaborator of mine, is the Elsie Inglis Professor of Clinical Reproductive Science at the University of Edinburgh and co-director of the MRC Centre for Reproductive Health. He trained in Edinburgh on a WHO research fellowship working on hormonal male contraceptives. This was followed by subspecialty training in reproductive medicine and followed by a year of training in San Diego. Richard works clinically in infertility and reproductive endocrinology and also provides a specialist endocrinology service to the Edinburgh Gender Identity Clinic. He has interests in both male and female fertility, with major aspects of this being fertility preservation and the effects of cancer treatments on fertility. Richard was previously chair of the Executive Committee of the European Society of Human Reproduction and Embryology, or ESHRE, guideline group on fertility preservation in women. He has also conducted clinical studies developing our understanding of novel neuropeptides in human reproductive function in men and women, and continues to be involved in trials in male contraception. He is a member of the Executive Committee of ESHRE and is a member of the Scientific and Clinical Advances Advisory Committee of the UK's Human Fertilisation and Embryology Authority. So today, Richard will present his talk, and then we have time for questions at the end. If you have a question, please type it into the Q&A button, which is located at the bottom of your screen. And there's also a chat button if you want to make any comments as we go along, either to the group or individually. At the end of the talk, I'll put as many of these questions to Richard as I can, given the time constraints that we have. I'll leave it here and hand it over to Richard, who's going to present on female fertility and cancer, prognosis, protection, and preservation. Thank you, Richard.
Well, thanks very much, Ray, for that lovely introduction. And it's a great pleasure and honour indeed to be speaking at this Lloyd Cox Lecture 2022. Terribly sorry, of course, not to be with you in Adelaide. But anyway, lovely to do this, and I look forward to some discussion afterwards. So I'd like today to talk about some of the work we've been doing regarding female fertility and cancer, and I hope you'll excuse the cheap alliteration of prognosis, protection and preservation. But just to highlight that it is indeed a great honour to be speaking at this memorial lecture of this truly remarkable man who was your foundation professor in the University of Adelaide, a real pioneer in reproductive medicine, in ovulation induction, IVF, artificial insemination, abortion rights, all still very and perhaps even increasingly important for us all to stand up and speak about these important issues today. So many thanks indeed for this invitation. So when we think about fertility in cancer patients, this is really very much a growing area. And a lot of this is related to the success of our colleagues in oncology in turning many of the conditions that would have been fatal when 40 years ago into very survivable conditions. And we now have a rapidly growing population of reproductively aged young people following survival from cancer. Excuse me if I'm only going to talk about females today rather than males. Fertility is clearly a very important issue for these patients, but it comes within a broader survivorship agenda that we need to recognise as part of a bigger burden often that these patients have to bear. And many of them have other significant health issues as well as potentially compromised reproductive function. There may be other issues that impact on their fertility in a sort of non-biological manner, and indeed particularly survivors of brain and CNS cancers have a reduced chance of marriage and cohabitation. And there are also social and psychological issues, perhaps concerns about life expectancy, perhaps concerns about whether there might be a recurrence, or indeed whether going on and enlarging or completing one's family may impact on that recurrence. And we're going to address that particular point specifically in a minute. So indeed, my first area here then is the fertility prognosis in these patients. So we're increasingly familiar with what the actual chemotherapy, radiotherapy actually does to the ovary. And I think this is a useful schematic just to illustrate that, with, of course, loss with many of these cytotoxic agents of the growing follicles resulting in amenorrhea. But of course, it's the impact on the primordial follicle pool that is the most important for the long-term function. And if that is sufficiently depleted, it results in premature ovarian insufficiency with infertility and, importantly, estrogen deficiency. But in many women, there will be a degree of recovery of the growing follicle pool from the surviving primordials, resulting in the potential for fertility. And one of the questions is that fertility going to be normal? Is it going to be reduced? And of course, how long is it going to go on for? Might there be a reduced duration of reproductive lifespan? And in the short term, we can assess these things with biomarkers, and measuring anti-Müllerian hormone has really become prominent in this. And historically, the literature has relied on measurement of menstrual function. Is a woman having her menstrual cycles or not, as the key index of ovarian function, which of course has its major limitations. And these are useful, and in short-term studies they can be extremely informative, but really we want some of the clinical outcomes to be able to really inform our patients about their fertility, their reproductive lifespan, their age of menopause, and for our more younger patients, the importance of whether they're likely just to go through puberty naturally or not. So we've been involved in looking at this for a number of years, measuring AMH in cancer patients, following them through this journey, and have made a number of observations and contributions in this field, highlighting that actually an AMH level before cancer treatment will predict long-term ovarian function, as you might expect, but it absolutely is the case and has been confirmed by many others. We've more recently been exploring the value of AMH for post-cancer diagnosis of POI and how accurate it can be, bearing in mind this period of recovery that can be of variable duration. And more recently still, we've actually been exploring the immediate post-chemotherapy prediction of AMH and whether that can predict recovery in certain groups of women and whether it does indeed have value in that. And that's particularly important in the context of breast cancer, where the oncologists will be wanting to know whether ovarian suppression is needed or whether they can move on to different endocrine therapy, depending on whether or not there's going to be ovarian function. So that's very much ongoing work of very immediate clinical implication. Just to illustrate one example of the type of study that we've been doing in this is part of a large trial of different treatments for Hodgkin's lymphoma that we took part in a couple of years ago, where women were initially treated with a relatively low toxic therapy, ABVD, and then depending on their response, they were then either stayed on ABVD, whereupon you can see there in the blue here their AMH levels recovered, or if there was an insufficient response, they were changed to more damaging therapy, BRCOP, and you can see here there was really very little ovarian recovery thereafter, so much so that actually 3 years after treatment, the AMH levels differed by a factor of 100 between the two groups. And that, of course, is likely to have major impacts on fertility, but that needs to be addressed. Incidentally, it was also quite informative here to find out that actually age also, how much that determined recovery in the ABVD group, with women over 35 showing only a partial recovery compared to younger women with the same chemotherapeutic damage. But that's an aside. So we wanted to really think about, well, what really is the fertility of women after cancer? And that's a very difficult to do in a trial context because there's all sorts of, there's the size of the study you can do and biases involved in that. So we really wanted to get national population data on this. And we're fortunate in Scotland to have very comprehensive national registries that allow us to try and address this. And so we took the Scottish Cancer Registry, which goes back for these purposes 1981 through to 2012, so some 30 years of treatment there, and we linked that to maternity records and death records over that same time point and for a few years thereafter to link the cancer diagnosis with subsequent maternity. And this gave us then 10,000 girls and women up to the age of 40 at the time of cancer diagnosis over this time point. And of course, we then have population records, but we particularly did matching of these individuals, particularly based on age at diagnosis, but also the period of diagnosis and their socioeconomic status. But age at diagnosis is clearly the key thing for the match controls. And of course, you have to censor individuals at the date of death of their exposed match, so you can't go on having pregnancies and births after the cancer patients if they don't survive beyond a certain point. So when we look at these data and we look at the chances of live birth in women who hadn't had a baby before cancer, you can see the breadth and extent of the impact of this cancer and its treatment across the board. Overall, you can see here in the top line, the hazard ratio for a subsequent live birth was approximately halved. You can see with this size of population, we can still have relatively narrow confidence intervals about this. And you can see here in this list of a whole range of diagnoses with brain, CNS cancers, leukemias having the biggest impact on reducing your chance of a live birth, through lymphomas, breast cancer, bone cancer, all having a greater than a hazard ratio of less than 5, so on average a greater than halving of the chances of live birth. And even cancers that you think might have very little impact, thyroid cancer, skin cancer, they still had a measurable impact reducing the chance of live birth in these women. So if that chance is reduced, we also wanted to know, well, what happens to women who are able to have a baby after? What is their family size? Do they go on and complete their families normally, or is there an impact on that? And using the same analysis, we were able to look into this. And so this is looking at what we termed the fertile survivors. So these are the women who had at least one pregnancy after their cancer diagnosis. So that makes them, in this analysis, a fertile survivor compared to their age-matched controls. And you can see that across the board, all diagnoses, there's a significant reduction in the number of children that cancer survivors have, even when they're able to have children. And that actually was, I think with the one exception of cervical cancer, true for all diagnostic groups. And it occurred even in women who'd had their cancer in childhood. So I've just got two examples of specific diagnoses here. You can see for Hodgkin's lymphoma, if we look at the under 14s, you can see that the family size was reduced to 2.3 from 2.7. And in leukemia, similarly, looking at the children, reduced from 2.7 to 2.0. So this isn't about the treatment causing a delay in your opportunity to conceive for a period of time. It's a lifelong effect, even if you're treated in very early life, pre-puberty. So what about then the lifespan of one's fertility after cancer? Is this because that they've had some treatment and that's reduced their opportunity, the duration of time they might be able to have a pregnancy, bring their menopause forward, shorten their fertile lifespan? Well, so we looked at that as well in this same analysis. So if you look at the controls, and here I'm just going to show you the data on breast cancer as a key example of a relatively late reproductively aged diagnosis generally, and what impact that might have, because you might see the biggest impact when the cancer is diagnosed at that time. So this is the controls, and as you can see, younger women have a longer time to fall pregnant than older women. It goes down. So by the time you're in your later 30s, pregnancies occur on average up to about 3 to 4 years later. But we look at those age-matched women who had breast cancer, you can see that relationship no longer holds. And in the younger women, their duration of their fertile lifespan was the same as in the controls, and it progressively didn't shorten, essentially. And so there was a longer duration over which the breast cancer survivors went on having children or having pregnancies of 1.6 years in this age group. So that was rather surprising, and we really hadn't expected that. And we thought, well, how else can we explore this? And we thought, well, the group that we really would expect to see this after breast cancer would be those who we know have been exposed to chemotherapy. So we were able to look at that population specifically, and you can see that even in those women who we knew definitely had received chemotherapy, their duration of having pregnancies was still slightly longer than the controls. So there was no evidence here that the reproductive lifespan was shortened by women after cancer, and specifically after breast cancer chemotherapy. So we looked at this a different way by looking at the time distribution of pregnancies after cancer as well. And this graph shows that for all diagnoses, and with the sort of pinky colour, the controls, and the teal being the fertile cancer survivors. So of course, again, this is only women who had at least one pregnancy after diagnosis included here. And you can see there is the expected initial delay, and then there's perhaps what you might call a catch-up period. But the important consideration here is that this tail end, the lines are really very close. There isn't a truncation of time over which cancer survivors are able to have children. And if we look at this again with breast cancer, you can see that this delay and the later peak is perhaps more exaggerated in this population of women. But again, when you come down to the tail, this is very, very similar in these two groups of women. So no evidence of a shortening of their reproductive lifespan. They carry on trying to have children for at least as long as their controls. So this is important, and I think this sort of sheds light on our understanding of what cancer treatment might be doing to the ovary, and we really need to look into what the biological as well as, of course, the social mechanisms that underpin this. So one of the things about breast cancer and pregnancies thereafter, there are actually remarkably few women who go on and have a pregnancy after breast cancer. You can see here, this is age-matched controls. About 23-24% of them will have a baby after breast cancer, whereas the those who've had breast cancer, you can see that is reduced to about a half. But actually, things have been getting better over the years that we did this analysis. You can see back in the early 1980s, the hazard ratio was about 0.2, and you can see how it's progressively improved over the years, which is excellent news. And this is, of course, going to be impacted by all sorts of factors. But one of the key things here is about, well, how safe is it to have a pregnancy after breast cancer? Are there concerns about recurrence? And this has been a thorny area in the field for many years. At the moment, only about 5 to 7% of women are having a baby after a breast cancer diagnosis. But with changing demographics, women having their families later means that more will not have completed their family at the time they have that diagnosis. And of course, there's more and more fertility preservation in women with breast cancer. That's the most common diagnosis for women, to store their eggs in that oncofertility environment. And so those women, of course, are intending to have a family thereafter. So how risky might that be, or is it safe? And you can see from this survey that Matteo Lambertini did a couple of years ago, about a third of oncologists still have concerns about this. So we felt that this was an opportunity for us to explore this and these national databases. And over this period of time, within these databases, we identified some 5,100 women with breast cancer. 290 of them had gone on to have a baby, a live birth, after their breast cancer. In fact, 66 more than one. And we excluded women diagnosed during pregnancy as a bit of a special case. And we identified as effectively the controls, the unexposed cases, 4,800, rather less than half of whom had never had a child, either before or after, and 2,600, a bit more than half, who had a child before breast cancer but didn't go on and have another one afterwards. And we matched them on about a 6-to-1 ratio, with a minimum of 4 unexposed for each case, an average of 5.8. And again, you have to take account of a guaranteed time bias, whereby this is all about survival. You know, if you don't survive to the time you might have been pregnant, then you don't have that baby, of course, and that applies to the controls. So the analysis is essentially survival from the time of the live birth, rather than from the time of diagnosis. So if we look at this overall, and I'm going to show you 2 or 3 different analyses here. In the yellow, this is the women who went on and had a baby after breast cancer. The blue is their unexposed controls who didn't have a baby after breast cancer. And overall, you can see that women who had a live birth after breast cancer had improved survival compared to those who did not. Hazard ratio of 0.65, quite narrow confidence intervals, and you can see the overall survival at 20 years, so this is a long time after diagnosis. You can see that it actually is 64.6% in the women who didn't have a baby, 73.9% in women who did. So quite a big difference in these 2 groups. We went on and did some sub-analysis to try and identify which factors might be relevant in this, and obviously to be as robust as possible, that these are not such a highly selected group of women who might be. And I'm not going to go through all of these, but I'm just going to show you some information about the top 3 of these sub-analyses. So if we look at women who had not been pregnant before diagnosis, so this is of course particularly important, so women who haven't started their family at the time of this diagnosis. Again, we found that a significant improvement in survival in those women who had a subsequent live birth. Hazard ratio 0.56, confidence intervals you can see there. So a clear apparent survival benefit for those women who had a baby after breast cancer. If you'd had a baby before, the hazard ratio was also a bit reduced, but you can see the confidence intervals across 1, so not a significant effect, but certainly no evidence of an adverse effect in this group, which is of course the key worry. If we look at age, we found some really interesting results as well. And these types of analysis, remarkably, have never been done before. So we found that actually the youngest group, despite that it was a relatively small size of group, they had a seem to have a very clear survival advantage or reduced mortality in those who'd had a baby after breast cancer. Hazard ratio down to 0.3 with quite wide confidence intervals, but clearly not crossing unity. And as the age of diagnosis increased, you can see this age group here in their later 20s, still an apparent improvement in survival. And by the time they entered their 30s, it was the confidence intervals were crossing unity and a very clear no effect either way by the time the women were in their late 30s at diagnosis. So younger women seem to be having a different response here to older women. And as you saw before, younger women and those who've not been pregnant before. What about how impactful is it on how quickly you want to go on and have a baby afterwards? And this is clearly of huge import to a lot of women in this situation. So we looked at before and after 5 years. So those who went on and had a live birth within 5 years of diagnosis, their survival was also increased. You can see here this hazard ratio with this confidence intervals and the survival in the yellow again compared to the blue, women who didn't have a baby after breast cancer. And if we look at those who had a live birth beyond 5 years, you can see a slight improvement, but again, it's confidence intervals crossing unity, so no significant effect, but clearly no significant adverse effect. And we found with the other analysis that I'm not going to show you in detail, with the tumour stage, the estrogen receptor status, again, none of them showed a detrimental effect of a live birth after breast cancer. So this is really very positive information to our patients, and I think it's particularly important for those who are coming forward for fertility preservation, because this really supports their prospects for future pregnancy and birth in the youngest women, those who haven't been pregnant before, and those who want to have a baby within 5 years of diagnosis. So this is all, I think, really clear, positive clinical information we can pass to our patients. So that's all very well, but how might we be able to protect women? You can see that that the overall impact on fertility after cancer diagnosis is markedly reduced. How might we protect that? Well, one way would be to do less damage. And I'm just going to show you a little data from this trial. Apologies for the rather burdensome title here, but essentially this is an RCT in pediatric Hodgkin's lymphoma that occurred across Europe. Took many, many years to undertake this study, and I was just one very small cog in this wheel trying to provide some reproductive impact, and it was published just earlier this year. And so essentially the key question here was, can you safely replace procarbazine, which we know to be dramatically gonadotoxic, with dacarbazine, and does that actually have less impact on reproductive function? So the overall survival, there was perhaps slightly reduced survival, but overlapping confidence intervals, so no significant difference in long-term survival in these two groups. And actually, in those who had radiotherapy, the lines were even closer, absolutely superimposable. But how toxic were these two regimens? Well, this is the data in the girls. Here we were looking at FSH levels at last follow-up visit. A modest proportion, I must admit, of the total population of the study, but you can see here, this is the proportion of girls with of girls overall versus their FSH levels, and you can see here very clear differences between those exposed to dacarbazine and procarbazine. And if you take an FSH cutoff of 25 as being indicative of premature ovarian insufficiency, you can see here, that's the dotted line, that it's down here for procarbazine and it's actually up at 1 for dacarbazine. So 27% of the girls, the young women that had been exposed to procarbazine showed a high FSH level over 25, but none of those who had been exposed to dacarbazine did. So a clearly beneficial reproductive function. And of course, that's just a single cutoff. You can see here at lower FSH levels where you've got perhaps some more partial damage, you can see evidence of a difference between the two groups. And that benefit occurred in boys as well, in the males. You can see, again, this is FSH levels. So here we're talking about the procarbazine again in the red, and you can see, if anything, the lines are even further apart than in the girls. And FSH over 10 as indicative of damaged spermatogenesis, you can see that that was 66% of the boys, the young men sampled after treatment, showed a high FSH compared to only 9% after Copdac, after the dacarbazine exposure. And we had some semen samples. It's always very difficult to get semen analysis in this type of thing, but we did get some, and actually 83% of the semen analyses after procarbazine showed azoospermia, whereas none of the ones after dacarbazine showed azoospermia. So not without some gonadotoxicity in boys, perhaps dacarbazine, but clearly dramatically less than the very damaging effect of procarbazine in this group. So very, very positive results here, clearly showing the option of doing much less damage to these children and adolescents, but while still curing their Hodgkin's lymphoma. The other approach to protection that's been explored over the years, and I'm sure you have some familiarity with this longer ongoing saga of whether GnRH agonist therapy during cancer, during chemotherapy, can be protective. And there are a number of large RCTs, 3 or 4 large RCTs, that have all come up with a remarkably consistent suggestion that actually in breast cancer, perhaps not in other cancers, but in breast cancer, GnRH agonists can reduce the risk of ovarian insufficiency after treatment. This particular study was the UK contribution to this field, and again, I was very honoured to be able to take part in this as the sort of the reproductive person. And this is the key finding in terms of ovarian function by history and by classic biochemistry that we had. So you can see a reduction in the proportion of women who are amenorrheic, and this is 12 to 24 months after completing treatment. And where we had a specific diagnosis of POI, you can see that was really quite markedly reduced from nearly 35% to 18.5% in those treated with goserelin, the GnRH agonist, during treatment for their breast cancer. But all the studies that have been done on this have really focused on this diagnosis of ovarian failure, POI, slightly different ways of doing it, with and without the GnRH agonist. And long-term fertility has really, or even short-term fertility, has not really been an outcome for these studies. In this study, the option trial, we did actually, I think it was the only one of the big trials that actually tried to measure AMH in some of our patients. Again, not all of them, so there's potentially a degree of selection bias, but actually we found no differences at the end of recovery in AMH levels in these two groups. So in the blue here, you see the controls, and the green treated with the GnRH. It's a log scale, so the differences are perhaps, just because otherwise this would be absolutely invisible, but actually at the end of this 2-year follow-up period, there was a 95% reduction in AMH levels in the controls and a 93% reduction in those treated with the GnRH agonists. So really very little difference. And so one therefore would wonder whether this will translate into a long-term fertility preservation. And I think the difficulty we have now is this has become such a standard of care as a ovarian protectant that to do really good studies in this will be challenging, and they will be more observational rather than the RCTs that these data are based on. So what about preservation itself? That's the third theme we have here. Well, I was very pleased to be asked to be the chair of the ESRA guideline group that published on this after a couple of years' work, a very substantial evidence-based guideline that we produced, now published in 2020, and you can see that's a picture of the bit on the website, and of course it's freely downloadable by all. And this is the pathways that we identified through the identification of the patient, the intervention, the different sorts of storage, and of course the rather complex subsequent usage options that are currently emerging from this. And I just want to say a few words really, particularly about the ovarian tissue cryopreservation, as that's the field I've personally been most involved in. So one of the reasons I wanted to talk about this actually was to highlight the contributions of these two individuals, David Baird and Roger Gosden, both pioneers in the field in Edinburgh at the time they were doing this work, but actually, and of course David's very sadly died earlier this year, as I'm sure many of you are aware. But I wanted also just to remind anyone in the audience who isn't aware that a lot of David's formative work developing his interest in mammalian reproduction using sheep occurred during sabbaticals he spent in Australia, and particularly actually in southern Australia, with a lot of close collaborations with colleagues in Adelaide who were so supportive of his work in this field. And this work he did in fertility preservation really was based on his use of sheep as a large monoovulatory model where you could do appropriate surgery, you could do multiple blood sampling, and relatively similar reproductive control mechanisms as we have in humans. So this was essentially a great development building on his work in South Australia. So what he and Roger demonstrated was that you could remove the ovary from a sheep, you could remove the cortex, freeze it, thaw it and put it back, and that could result in live birth after, in this instance, natural conception. And that is Elmore, the first large mammal born from frozen strips of ovary. And what David and Roger actually demonstrated, and a lot of scientific work from that period, really actually still stands today. And what they demonstrated, confirmed by current clinical work, is that in the great majority of instances, you can restore ovarian activity by replacing cryopreserved ovarian tissue, but most of the follicles are lost. They calculated about 2/3 are lost. So that remains an ongoing problem, and still there haven't been significant developments in how to overcome that. But current clinical data around the world suggests that something like 1/4 to 1/3 of women are able to go on and have a successful pregnancy after this, but there remains this key problem of potentially malignant contamination of the ovary in particularly the hematological cancers such as leukemia. But in young girls, this really remains their key fertility preservation option. And this is a laparoscopic view of a 7-year-old's pelvis. You can see the prepubertal uterus down there, and here an ovary showing antral follicles actually, even in this prepubertal girl. And to give you a scale, these are 5mm diameter instruments. But it shows it's possible, should one want to even dissect off the ovarian cortex, even at this prepubertal age, where all the primordial follicles reside. And it has key advantages, not just restoring fertility, but also restoring endocrine function, all the widespread benefits of estrogenization. And I think another real advantage of it as well is the possibility of natural conception. And current analysis suggests that perhaps a little over half of the babies that have been born from this have been naturally conceived, which I think is a huge benefit to our patients. It is, of course, a significant surgical intervention. We've mentioned the risk of malignant contamination, and there remains uncertainties as to how much tissue to remove and how to do it and how to replace it. But I think another key area of this is how actually to choose the right patients to do this for, because it is a significant intervention. It's not without risk, and it really needs to be offered selectively. And this was how we addressed it in the ESRA guideline. We discussed this issues of individual assessment, multidisciplinary, and here's a sort of a checklist of intrinsic factors specific for that patient and extrinsic factors of what's going to be done to her that puts her at the different levels of risk that can then be brought into the discussion with her and her parents or guardians. And we've been particularly interested in following up patients after cancer in this age group to see whether we, in our practice in Edinburgh, have been able to try and select the right patients for this, and therefore select those who are most likely to have gone on to show premature ovarian failure thereafter. And this was an analysis that we did a few years ago now for up to 15 years of follow-up of this group of patients to determine whether those we had offered ovarian tissue cryopreservation were more at risk of POI than those not. And you can see there was a huge difference in the risks between the two groups. It wasn't perfect, but it was actually really quite good. And the key aspect of this analysis to bear in mind is that our denominator here was all girls under 18 in southeast Scotland. So there was no selection bias here. It was the entire population of under 18-year-old females with a new cancer diagnosis over this period of time. Of course, this will evolve over time. These lines will change and develop, and so we've recently been reinvestigating that with some more recent updates. This is work by Kathleen Duffin, who's a paediatric oncology trainee, and Ruth Howie, who's actually just been appointed as a consultant post in our fertility unit, so it's more reproductive perspective. And you can see that the lines continue to be really very separate in those offered versus not offered, which is encouraging. But what also emerged more in this subsequent, more recent analysis is actually, although the risk of POI is much, much lower in those where we did not offer ovarian tissue cryopreservation, half of those who did develop POI in that group had done so after relapse of their disease and subsequent treatment, rather than the initial treatments that they were given at the time of the initial diagnosis. And it was really the time of initial diagnosis where we had primarily been just having the conversations about the ovarian tissue cryopreservation. And at time of relapse, there are often more urgent considerations in terms of timescales, previous damage already partly sustained by the ovary. So it's a challenging and complicated area to address, but it really highlights that's a key area to be taking forward. We also identified that actually, even in an area in our clinic in Edinburgh, or the paediatric oncology clinic in Edinburgh, where there's a relatively high awareness of this, actually documentation of ovarian function in these survivors was really quite poor. There was a lot of missing information in this, and that may be because it wasn't recorded if it was normal, or it may be that it wasn't assessed. I suspect actually the likelihood is mostly it wasn't recorded when it was normal, but it doesn't help with this sort of analysis, and it doesn't help document that reproductive function was or wasn't normal in these patients. So this is actually all part of where we're taking this now, is part of trying to establish more robust pathways for fertility preservation for all our patients, male and female, across Scotland, building this more into the National Health Service reproductive medicine portfolio, which really it hasn't been in the past. And we've had very clear national criteria for access to assisted reproduction in Scotland, unified across the different health boards, so there's no sort of postcode lottery, as it's often termed. And now, as I say, we're trying to build into that access criteria for fertility preservation. It will be mostly patients with cancer, but it's very much other conditions as well, other medical conditions, also for the transgender population, and of course males as much as females, although I focus very much on the females today. So I want to just wrap up by thanking the really large number of people who've been contributing to the large amount of data that I've discussed with you today, and indeed many other studies that have sort of gone into this sort of field of work that we've been working on for quite a number of years. I've mentioned David before, a wonderful pioneer, a wonderful friend and mentor that I was so privileged to work with over quite a number of years, and his loss has really been enormous. Hamish Wallace is a paediatric oncologist, also actually now very recently retired, but he's been immensely instrumental in bringing this really challenging area of surgical interventions for fertility preservation into a paediatric oncology context, and developing those links and supporting his colleagues in thinking that this really is something we should be doing for these young and challenging patients. Evelyn Telford has been a stalwart, providing fantastic interest and expertise in laboratory studies that I haven't really had a time to discuss with you today. And Tom is a mathematician and statistician at St Andrews, who's been so pivotal in many of the studies that we've done, particularly those involving the national databases that I discussed with you today. And I also want to thank just a an absolute myriad of adult oncology colleagues who've contributed to so many of the studies. David Cameron, his colleagues at the breast unit. Peter Johnson was the chief investigator on the Rathel trial in lymphoma that I discussed, and Bob Leonard was the lead on the option trial with the GnRH agonist that we discussed in breast cancer. And again, my thanks to the organisers, and it's been an absolute honour to speak in memory of Lloyd Cox and his phenomenal pioneering work that all of us have it incumbent on us to continue with and to develop further. So thank you very much, and I'll be delighted to try and address any questions you might have.
Thank you, Richard, for that great oration. That was really, really, really fantastic. And it represents quite a lifetime of dedication, work, research, academic endeavour to be able to get to where we are today. So I'm hoping you're going to be able to answer some questions, but can I just test that I've still got contact with you?
Yeah, loud and clear. Right, Ray, thank you.
Good, excellent. Okay, so there's been a couple of questions that have come through on the chat line. Sarah Robertson asked a long one, but I'm not going to read it out because she's actually online. And Sarah, are you able to, I've let you speak. If you can unmute and ask your question directly, that would be great. Let's see if she's still sitting there. No, she's not coming on. Anyway, whilst we're waiting to see if she does come on, there was a questions about hazards ratio. And I think if you're not familiar with them, at one stage they were going higher on one of the graphs, but I think they were below 1, and they appeared to be lower, particularly with age and things like that. Can you just tell us the good news and the bad news about fertility preservation over the years, and then also the effects of breast cancer treatment in terms of...
In general speaking terms, Ray.
Yeah.
So absolutely, I think the issue here is that breast cancer and its treatment do have a very major negative effect on fertility. That's the key thing, and although those patients make up the single most common diagnosis of women presenting to want to talk about fertility preservation. It's been an ongoing area, as we discussed, about the risks of potential fertility thereafter. But I think that this has now become, a really established branch of medicine, and I think that's such an important development that patients should expect a discussion of their situation and their options. And I think that's a really key thing, that the whole field has merged from this being a niche area to really mainstream medicine.
Okay, good. I just had to mute Sarah, but I'm unmuting her now. Sarah, do you want to come on? You were making some noise there. I assume that was your microphone.
Hi, Richard.
You've got a couple of questions now, Sarah.
Oh, well, look, I'm out walking the dog. I'm just trying to get away from the barking dog. Thank you for an amazing lecture. That's just very impressive, and obviously important area, and the work that you and your colleagues have achieved is tremendous. We're biologists, some of us, and interested in the underlying mechanisms, and especially I'm struck by the relationship that you showed us in the increased lifespan survival rates of women who had pregnancies. And I wondered if you could tell us if you think there's a causal relationship, or is it simply that they're women with different sort of life goals? And if it's a causal relationship, what's happening? And could microchimerism be part of the explanation?
Gosh, that's a very interesting suggestion, Sarah. I guess I'm really not competent to give you any sort of intelligent answer on that, I'm afraid. But I think it's very intriguing. I guess if that was the case, you would you not expect those women who had been pregnant before to also show a benefit? Would that be an important part of that mechanism as well, rather than just those who had a pregency afterwards? Or that might be a group that could be explored.
Right.
We didn't find...
the theory with microchimerism is that the fetal stem cells can circulate in the maternal body and find signs of tissue damage and set about repairing those damaged tissues. So, it may well be that you actually need the tissue to be in place before the benefit of the circulating microcardiac stem cells can be delivered.
Yeah.
Yeah.
Well, actually, within our data, when we looked at women who had been pregnant before or not, we found that the apparent benefit of a subsequent pregnancy was in those who had not been pregnant before, whereas those who had been pregnant before, who you'd expect to have this maternal microchimerism, actually there was no positive or negative effect. So that would actually fit with your hypothesis, I think.
Okay, so Sarah, we might mute you now and let somebody else come on with some other questions, just because the line is pretty awful at this end, Sarah, whilst you're walking your dog. So Richard, I was going to ask you about the delivery of some of these fertility preservation techniques. In Australia, we have different specialists. You've got the oncologist, you've got the surgical person, and they're there with the patient that's got cancer and they need to do the surgery and whatever. And then the fertility preservation techniques are delivered by IVF clinics and ONG type people. And quite often there's not a lot of talking between those groups. Is that a problem over where you are? Because it seems to be a problem here in Australia.
Well, it's certainly something that absolutely needs a huge amount of work to overcome. Yeah, I mean, and locally within Edinburgh, our main cancer centre is based actually at a different hospital across the city, so that doesn't help. Although actually the Children's Hospital has actually now moved to where our main hospital base is, so actually that has improved for the more pediatric. But absolutely building these, not just actually building these lines of communication, but ongoing maintenance of them is absolutely key to this, because you need urgent referrals. You essentially need a dialogue whereby the two teams have the same thought processes, so they're all streamlined. So in reproductive medicine, we intrinsically think in a different way to oncologists, and it's a matter of getting together so we start thinking about the same things for these patients. And as I say, repeated building of these links rather than just doing it once and expecting it to last a long time is absolutely essential. But it does seem to be moving to being better. For example, within the breast cancer field, the breast cancer specialist nurses are absolutely key as sort of patient advocates to make that happen, and that's really successful as well.
Actually, that's something I hadn't thought of. Maybe because I was involved with the group here in Adelaide, and it seemed to me like we were talking to the clinicians, but maybe we should have been talking to the nurses to get that to happen.
Yeah.
Yep. There's a few questions online, but I'll throw a quick one to you about the in vitro approach to maturing oocytes that you and Evelyn have been working on, and the oncofertility program in the US worked on. What's the sort of take-home message from all of that sort of work at the moment?
From in vitro maturation.
Yes.
So the current status of where we are is that it is possible to grow primordial human follicles in the lab in a piece of tissue. You then isolate the follicles from the tissue, and they can grow up to a metaphase 2 oocyte. You can get resumption of meiosis, extrusion of the polar body, and you get an oocyte that looks like it's ready to be fertilized. We haven't progressed beyond that to fertilization, and I'm not aware that anyone else has either, but certainly it looks like you can grow from a resting follicle right through to a cell that you think could be fertilized. Now, that's quite some way from being able to think that this is going to be safe for clinical practice to actually turn that into a baby. We learned from the challenges in the mouse where initial work did not produce terribly healthy mice, but I think that we're certainly making progress in that field, and it's a challenge just to think of when that will become a clinical reality. But you'll also be aware of the improvements in IVM from the other ends, moving towards aspirating more immature follicles. A lot of work, of course, done in Adelaide and where you and Sydney on that, as well as elsewhere in the world. And so that the two fields are perhaps approaching from opposite ends to try and improve that.
Good. Yeah, it's just seems to be that it's been a long time coming. I mean, the researchers were working in that area back in the 90s, and I guess that means
it's been very slow, but I think then the more clinical IVM has really changed in the last few years. Actually, it seemed like it was as you say, there was a lot of time with very little progress, but now, there've been some recent improvements with the Kappa IVM seems a major step forward.
Good. Okay, so there's a couple of other specific questions online. And I'm thinking we're running out of time because it's 1 hour. And I know, Richard, you have to run off to another meeting. And what I ask is that the other people that put up some specific questions that maybe they can email you, Richard, if that's okay.
Absolutely, yeah.
Yep.
I mean, I see Mariano's last question there. Yeah, we did do a matching as well, Mariano, and both in stage 1 and in other stages, the major finding was absolutely the same. So these are not patients. The women going on to have this survival benefit are not just because they had an earlier stage of breast cancer at all. That's absolutely doesn't hold up.
Okay, all right. Look, Richard, we're going to wind up here now. That's a complete hour, and let everyone else get on with their day's work or their evening's activities. So, look, thank you very much again for having accepted this invitation to present. This has been recorded, so that means that people can play this online at a later date. And again, thank you very much for presenting this today. It's just been an outstanding talk. The questions were good. The topic was one of those ones that doesn't get a lot of airplay, I don't think, but it's been worked on now for decades, and it started from a lot of basic research. You mentioned Roger Gosden and David Baird in particular, who I did do some surgery with once on sheep many years ago. And again, thank you.
Well, thank you very much, Ray, and it's been an absolute pleasure. And as I say, I'm very honoured to be able to recognise the memory of Lloyd Cox and his amazing achievements. And hopefully this was up to that standards. Thank you.
It certainly was. Thank you, Richard. Bye, everyone.
Okay, bye, everybody. Nice to speak to you all.
Okay, bye.